Kia ora. Welcome to the New Zealand SimNurse NZ podcast. My name is Erin.
And I'm Alison.
And I'm Marie.
We are the three nurse educators from the Douglas Starship Simulation Program based in Auckland, New Zealand. We're all passionate about our work, and so we'd like to welcome you to join us as we have a range of conversations about all things sim.
Tēnā koutou, tēnā koutou, tēnā tātou katoa. Kei ngā maunga whakahi, kei ngā wai tukukiri, kei ngā mā tawaka o te motu, ka nui te mihi kia koutou. To those who connect to the mountains, the rivers and oceans across the land, hello and welcome to you all.
We are incredibly excited to have with us on the podcast Dr. Jabeen Fayyaz. Jabeen is an esteemed professional at the Hospital for Sick Kids Children in Toronto. She contributes significantly to the division of Pediatric Emergency Medicine. She has a diverse skill set and a commitment to medical education. Dr. Fayyaz is the inaugural SimKIDS Medical Director, Staff Physician and the Director of the International Clinical Fellowship. Her role as a Sim Educator and Resuscitation Lead underscores the dedication to enhance emergency response strategies. She is an Assistant Professor at the University of Toronto. Dr. Fayyaz is actively involved in academic pursuits, brings a wealth of knowledge to the field, and she is driven by a global perspective. She holds leadership positions in international organisations such as IPSS and Inspire, and she serves on the board of directors. She extends her influence internationally as a visiting faculty at institutions in Pakistan and India and contributes to healthcare education and collaboration on a global scale. And I definitely stalk Jabeen online, particularly on LinkedIn and Twitter, and she gets out there, man. She is out there doing stuff all the time. And, you know, we did a little test record with Jabeen, and I did check with her, and she does sleep. But, yeah, she is a force to be reckoned with in the sim world, and I'm so incredibly excited to have you here with us here today, Jabeen. So welcome to SimNurse NZ.
Thank you so much, everyone. It is my pleasure to be here and to share some of the experiences or knowledge that I have been able to work upon or gather in the last couple of years. So thank you so much for inviting me.
You're most welcome. And I kind of feel like this might not be the only time, hopefully, but we'll see. So, Jabeen, you've got your fingers in so many pies, so to speak. Would you be able to tell us a little bit about this kind of generative AI and simulation and some of the outreach VR simulations you've been involved in?
Yeah, for sure. Basically, as one part of my professional identity is I have been trained in Pakistan, did my med school in Pakistan, and then worked many years in the faculty position capacity at Aga Khan University Hospital. So I always have this passion that how we can leverage simulation, which I get introduced like 7 years ago at SimKIDS when I was doing my simulation fellowship, that how I can leverage all these knowledge and learnings to a place where I am from, and also where it will make the most difference and how it can be very cost effective. So keeping that into my mind, then I continue to looking for low cost strategies. And then one of my colleagues from McMaster University, which is James Slowing, was doing a lot of distance simulation by using a virtual resuscitation room, which is originally incepted or created by Sarah Fuhe, who is also an emergency medicine physician. So this is my journey with distance simulation, capacity building, started with outreach countries like Pakistan, India, and now with it as well. So while we are doing this, as you all know, that there's now a boom of technology and everybody about AI. There's so much of AI. Everybody has some sort of AI. Either they are directly involved or they are willing to involve. luckily, I think we have been at a unique place, which is at the Hospital for Sick Children, where a lot of expertise are available in different areas. And we do have like one of my colleagues who did a fellowship with me. His name is Davin Singh. He's recently been appointed as a co-director for AI in medicine at SimKIDS. And while talking to him, as we have been very good friends as well, we come up with this idea that why don't we create self-directed virtual distance simulation scenarios where generative AI can be utilized, and learners have the leverage that they can run the scenario by themselves on their own time, in their own space, and then the AI can be able to debrief and later on in larger group, the facilitators can come in and only clarify some of the higher level queries. So what I believe this is going to be causing, I know it's being called as a disruption, but I think Educator, we all know that sometimes a little bit of disruption is important. Like when you put a stone in the water, there's a ripple effect, but it brings to surface some of the things which were not hidden. So I think that is kind of disruption I believe AI will be bringing. So it will provide opportunity for self-directed learning, a little bit autonomy into the hand of the learners, enable them in the simulation at their own place, space, and convenience, may provide an opportunity to be a psychologically safe environment and not to feel a little bit more embarrassed in front of their peers if they are kind of situations or scenarios which they want to learn. And I think we can also create through this technology some of the difficult situations which we still struggle to deal. For example, mental health crisis. And we as simulationists or simulation educators that during the COVID or after the COVID, at least in our emergency department, the mental health crisis presentation to ED has increased remarkably, like at least 50% increase in mental health crisis, which are presenting to the emergency department. So I think it is an opportunity for learners, not only in places where mental health is not being talked about, to learn about it, but also in North America or in well-developed countries where there's not a lot of opportunities for the learner to learn about this important area. I'll give you a small example. I was having a session, my colleague was taking a session for Pakistani learners a couple of days back, and they talk about heads history. And the learners there is completely unaware what is heads history is. Heads history is mental, sexual, social history, which is a part of any encounter. When you are taking other history, you will take about this history. And it is such a taboo to talk about mental crisis, sexual history, social factors in countries like Pakistan or India. Cannot talk about these things. So I think and that's why the learners do not get a lot of opportunities to learn about it. So using scenarios by generative AI, you can provide the learner with such opportunities. Also, they can do it as many times as they want to do it. And then it will be on their own pace of their learning. And we can provide them, like every learner is a different kind of learner, so we can provide them some of those opportunity that they can learn by generative AI scenarios in a way they actually like to learn, and make it a meaningful, useful opportunity rather than just coming in and not being engaged.
Sounds great.
Yeah, I mean, we've used VRR ourselves, virtual resus room. Kang, he brought it back from Canada when he came from his fellowship, and we did an episode on that. And we loved VRR. And I'm sure you guys, Ali and Marie, your cogs are probably spinning the same as mine of like, we loved VRR, but just the access of, it's still the same kind of struggle of trying to gather and corral the humans into the one place, be it online or in person with simulation. So I think that you guys are onto such a great thing here with this whole at your own pace, but you're also giving this feedback. Like, what kind of stage are you at with this? Have you got to the point where AI is debriefing, and what kind of debriefing is AI doing for these programs?
We have not been to that stage yet.
Yeah.
It is just in the very initial phases of conception. But yes, I have seen, like Davin Singh was able to show us that encounter, like as an example, when we are generating where a medical student is taking a history from a patient who is an AI patient. And then once that medical student has finished the history, the AI is able to provide the feedback that how the questions which were asked were relevant, how was the tone of the medical student, is that medical student appear empathetic or not to that AI patient, and what are some of the things that done well, and where are the opportunities where further improvement is needed. So I think the same plus delta methodology utilized for some of the scenarios which are very much straightforward, where there are not a lot of if and buts, and there's simple, straightforward, because resources are limited, educators' time is limited, and there's so much is expected to be done. So if they come with a baseline knowledge, then you can elevate that knowledge when in-person encounters are learning. So if somebody will say that it will completely replace, or it will be completely not to be introduced. So I think the right balance is the key, and finding out what are the objectives that can be met or enhanced by using those technology solution, and where it is not needed just for the sake of introducing AI in your curriculum to your program is not a right thing to do, in my opinion.
And I think we've had that discussion around VR as well. It's very relevant. I think there's a lot of people out there in the simulation community or in the education community who are scared of these new technologies and scared that it's going to take over. And I think it's from our point of view and from talking to a lot of people, it's not taking over, it's enhancing it in some way. These are new technologies that can just enhance what we're doing and kind of help out in ways that we've found areas difficult before, as you say, to kind of, get that subjective opinion across to people when you're marking or assessing. I think having that real taking away that real subjective opinion of an assessor and having AI, I think it's a really interesting kind of concept.
Slightly easier to receive more subjective feedback from
I think it's
computer
almost like
than
the
it is from a
RQI
human.
cart, isn't it?
Yes.
We've got the RQI cart from Laerdal, which is doing the CPR training now, and people tend to find the feedback a lot easier from a computer because you can't go wrong with a computer. It's not, it's not subjective. It's very objective, and it's.
And again, what you were talking about with the taboo subjects, like it's that same, with subjects that we all struggle, no matter what our background or culture or religion or anything. There's lots of subjects that we all struggle with, and again, having those be something that you can access in your own time, again, without being in a crowded room talking about embarrassing things, I think certainly for the first or second time is so valuable that, again, like you say, when you all come together, you can take it to that next level because you're sort of over the embarrassment factor, if you like, because you've listened to the words and you've got embarrassed all by yourself. And yeah, I just think it's the enhancement is amazing.
The psychological safety around kind of that whole piece is really, really fascinating, isn't it?
The potential for enhancement.
Yeah.
agree. No, I'm just saying you both have been bringing such an important point because these are small factors, but it does make difference. And especially like we always have been taught in our whatever educational courses we do that we have to take care of the types of learner or the learning styles, but like it is the reality. The new learners are technology enhanced
Yes,
learners.
absolutely.
For them, they need excitement, some excitement in their education to get them engaged. And
Absolutely.
these are the things, if they are put it in the right mix, they are not only elicit kind of excitement and engagement, that they will continue to be motivated to learn. And if you use it logically and wisely, sometimes these technologies have like a little bit of higher cost at the front end, but later on it can be very effective and it can be used for a very large scale as well. Like for example, one case that we have developed on VRR, virtual resuscitation room, I don't know how many times now, like 50 plus time we have used it. It's not for like there's no cost involved in it.
Right.
So I think with a lot of people focusing on low cost and the expandability of these technology-based solutions, there will be a lot cheaper options will be coming.
Absolutely.
Yeah, I love that. I love that you're thinking about equity so predominantly and thinking about this low cost setup staff, and you're out there proliferating all this information, which is really, really important. And I think that, you know, as simulationists, you know, you talk to other educators and like you say, Ellie, there's so much like fear around AI and things, and people just, you know, it's that whole early adopters versus late adopters. And, you know, I think in simulation we are quite early adopters. So it's really great to hear about this amazing work that you guys are getting up to. And we'll certainly be keen to tap in and hear more about it.
We're all about the disruptive technology in sim, aren't we? It's
Yeah.
how we roll.
Yeah.
Again, I think it's a little bit more around that taboo subject situation, isn't it? The use of AI with the translational technology that you talk to us about.
For
Talk
sure.
to us about
I'm
that,
very
please.
happy to share a little bit of details of the project, which is like almost in the write-up stage and will be soon be submitted to the journal. And it is about artificial intelligence-based language
Oh, yay.
interpretation in non-urgent pediatric emergency consultation. And the aim is to do a performance test and to do some of the legal evaluation of the AI-based language interpretation. We all know that definitely professional language translation is the gold standard. If you have the human person available, like for example, I speak Urdu and there's a patient who speak Urdu, the bestest I can go and translate. But this unfortunately is not available all the time, or sometimes the cost is a challenge that some places cannot afford it. So because of these two barriers, I think the primary focus that we have is to assess the performance of AI-driven language interpretation tools in facilitating communication between the healthcare provider and patient or caregiver, especially in the pediatric emergency medicine consultation, either for history taking, for counseling them while at the time of discharge. And we all know how important it is. It is important in every field, I feel like, but in emergency situation or acute care setting, it become more important because you do not have any previous relation with the patient. And if you are not able to talk in their language, which they understand the most, you might miss a critical piece of information that can lead to critical errors or mistakes. And one of the example, which is very near, happened that the patient was traveling back from Pakistan and the child was not immunized and have a rash, fever and a rash, which was thought as a viral exanthem. But then patient presented a couple of days afterward and 1 or 2 days afterward, and it turns out to be that was a measles. So that patient was in the waiting room, then non-acute care, then acute care. So you can imagine the patient was never put in isolation just for a small piece of information that get missed. And then there's a huge email that goes out that this much number of the people get exposed, possibly, etc., etc. So just to give you a gravity that by only missing a small piece of information, how much implication it can have, especially in situations which are acute care situations. So what was the project about is to use AI language translator, for example, Google Translate, because it is the most easily available. So we evaluate the use of Google Translate in non-urgent pediatric emergency consultation from a clinical and legal perspective. And there were 5 common languages were chosen based on the demographic of international speakers which come to our emergency department. And those languages were Arabic, French, Mandarin, Spanish, and Urdu. It was a whole kind of patient care interaction that was developed. For example, the one because I speak Urdu, so I was involved in Urdu translation. They did they created the whole history taking for a febrile child, and then at the time of discharge, the counseling. So what we did, we have a language, like a professional language translator available, someone which is one of the research assistant or research participant was there, and that was saying something in English, and then we were seeing whether it is able to exactly translate in Urdu in the same context or no. For example, if I ask, what is your name? So what is your child name? Why you are here for? So is it translating actually in Urdu ke aap kaise hain? Aapke bachche ka naam kya hai? Things like that. And is it relating to the same context or not? So what we found out that they are the results were for different languages is from 83.5 to 95.4. So those languages which are more close to English nomenclature are those where a lot of grammatical or context is not required. For example, French is the most accurate, 95.4, and Urdu is the least accurate, which is 83.5, because a lot of context, for example, for example, there's an example which I put it there that there's if I want to say how are you, so it is a different context if it is a younger person to you, older person to you, or you are there's a different connotation of that knowledge, is not exactly because how are you is aap kaise hain is word to word translation. So Google Translate can do word to word translation, but not the contextual translation. We find out that there is a need for continuous check of the back translation and adherence to the official language pronunciation. By doing this, the performance of any AI-related platform can be increased, and there is a need of informed consent that we should inform the parents that this is what we are using, for example, any AI language, based language app, and then to let them know that it might not be actually completely accurate. So it's an interesting experience for us because we compare it with a professional language translator, and I will be more interested to now test it that if there's an actual parent in front of us and AI-based translation of the language is being done versus not a translator who is a human body is translating to them how do they perceive it. It is the same perception or they perceive it differently, because human touch is always the will not translate your worriness now. If I'm saying I'm happy, so my language tone is communicating a lot of emotions, which I believe the AI language translator may not be able to translate that. So it was an interesting experience for the whole group. And I want to mention Julia, who is one of our research fellow who take a lot of lead in this project. And again, Davin, who is an AI lead on this project.
And you talked about increasing essentially the input to try and improve that accuracy. How does that work? Like, is that just a matter of using it more or critiquing? How does that work?
Yeah,
how can you possibly improve it?
I would say avoiding medical jargon a lot. If we are using a lot of medical terminologies, then it might not be able to translate it very well. Try to explain in a simple English language that they are able to translate more accurately. For example, is like prematurity. So prematurity was not being translated exactly in Urdu language as it should be conveying the message. It might be that your child is born before time, before like this, then it will translate it in an actual language that because your child is born before the expected months, that's why. So this is one of the example what I'm trying to say, that if you provide a less medical jargon and while you are talking and counseling the parent, then these AI models may be more able to translate actually in a language which will be making more sense in the context.
Right. Yeah. So it's more about how we use the technology, not necessarily about being able to improve the technology. And kind of like the way that I think about AI is, and maybe I've watched too much television, so please don't judge me, but like in terms of the more that you use it and the more information that it gains from the universe, from the metaverse, it grows and it learns and it's able to make itself better, for want of better words. And so like it's fascinating to me that you're saying we as the healthcare professionals or the people using the technology need to be like, that's where we need to moderate it in terms of making it useful for us, as opposed to it learning, if you like. And I don't know if I'm explaining myself well. The girls will help me out if I'm not, but it's interesting that we need to be the mindful ones in terms of because I mean that's often true when we're speaking English. I think like we need to be using less medical jargon and less medical language when we're actually just speaking in the same language to people. So it's so fascinating on so many levels.
Yes, and then the fact is they are all created like the initiation of these model or the language in which they have been created is all English. So I don't know what will happen after a couple of years because English is not the only language which spoken in the whole world. There are many other languages, but the most data that is being going in these AI models is in English language. So you can imagine that how it will get trained for other languages and then other cultures as well. So this is an interesting discussion, and I think we can continue to talk about it for hours.
Hours and hours, absolutely. So what do you think is the next step in terms of this stuff then, and like from your experience and from this project, where to next
us, like we find out some of the challenges that, for example, the accuracy of the translation and precision of the translation. Like for example, I find out the phrase which I was quoting because the question that was asked was, and do you remember if your partner got a vagina vaginal swab for streptococcus. It is a febrile infant with whom there's a father there, and we are taking the history from the father. About this, like, does the child at the time of birth was exposed to group A streptococcus or not? So the translation was done as like I will say in Urdu and I will explain what does it mean. आम तौर पर इसके 1 और 2,000 डायपर होते. The translation that was done was that there are usually 1 to 2,000 diapers. So it doesn't make any sense. What does it mean? So I'm just so here there's a vaginal swab, there's a streptococcus, and then we rephrase it that does at the time of birth your partner has any kind of infection, for example streptococcus, and any test was done, then it translated correctly. So that is why it bring up the fact that it is very important for us when are we using these translation models, what we are saying, because we need to be very careful that at that time what translation is happening we are not able to see. I know English and Urdu, so I can see both what command is given and what translation is being produced, but not everybody will be able to understand or read what they are translating. So being aware, I think being aware about its accuracy and precision. Cultural sensitivity, I again say in such project we get very much it reminded us that we need to be aware that in some language the context will be completely different when it gets translated. Like for example, sexual history when taken in English, it doesn't felt as awkward if you start using the same kind of translation or words in Urdu. So that is also, we need to be very aware. Definitely, there are legal and regulatory compliance for such applications should be there. What I meant to say that at least we inform the parents that this is a confidential data now that we are exposing this app to. And remember, this is going somewhere. We are not able to see it right now, but there is a data that we are feeding in this and it is going somewhere. So being aware of such legal confidentiality perspective and informing our patient, being very open upfront with them, and then taking consent. We don't take this like a written consent, but we do take a verbal consent. We tell them that this is the situation and we are doing this, and we do document in the chart, and a verbal consent has been taken from the parents for the knowledge for language translation, and
I think as well, like just letting them know that there's potential that it might not be accurate. So if I'm like, again, for me, not being able to to know that the Urdu is not correct, just letting them know at the start whenever you're using any sort of AI translation, because we pull it out of our pocket and is like, oh, this is the be all and end all, but just actually making them aware that it might not be accurate. So if there's anything that is very strange, please let us know and ask. Yeah. Ask us, because
completely agree.
We're all being guided.
That's
by
exactly
the AI.
What it is such a eye
for me that's
for
massive.
Us. And then I would say for next step, it is just thinking about how this AI and human collaboration will look like in next couple of years. Like I'm just thinking about it, and then I said, we collaborate with people, with system, with all the stuff, and we have been tuned ourselves like how to be more team player and to communicate better. But now one of our team player which is getting introduced is this AI. So we have to learn how this collaboration is going to look like when it's become a constant part of our teaching, learning systems, processes. So where to know each other's limitation.
Absolutely. Yes. Yes. Absolutely. Treat it like a human. Yeah. We've all got limitations, even the AI. I like it.
I'm fascinated by, and I'm just quite new to all of this. So can you just clarify something for me? When you talk about AI models, Jabeen, how did you decide what kind of models? Because, I mean, I have no idea really, and I don't know about the other girls, but I don't know how many models there are out there and how you actually decide on what model to use. Are they different ones for different things? Or, how do you actually decide on what AI model to use for the purposes that you
I
need?
would tell, and it's like in full disclaimer, that I'm also very, very new to these all AI models. And the only one which I am being a little bit more comfortable and start using it is generative AI. And generative AI is you provide some of the information to the AI, and that could be any kind of data. For example, you have given them a scenario, and that AI will create and some instructions, and the AI will be able to generate a kind of like rephrase it, or like, for example, I will phrase it to give an example. For example, I want to create a sepsis scenario. So I will choose a generative AI. I provide the age, the sex, a gender of the child, some of the core component that the presentation, how many stages I want. And then once I feed into how sick the patient on arrival is, and how long the stay of the patient, etc., what are the labs, etc. So it will completely generate a case for me, the full case with stages. So it is kind of an example of generative AI. Like, you provide some knowledge, some information, and provide them what is your outcome that you want to achieve, and that AI will generate it for you in a click. So that is kind of generative AI, and the benefit is that you can feed a huge amount of data. I was hearing from one of my colleagues that there will be a time that will come that you can actually, for example, sepsis or septic shock has different presentations. So you have 100 sepsis cases in a year, and they are automatically going into some kind of AI model, and then they will generate 5 cases which are based on actual real-time patient presentation from last 1 year. So this is the one of the examples of generative AI. The other is predictive AI, which is during my PhD in Harvard, we utilize it. And predictive AI is for example, I used it, so I'm using the same example to explain, is we were doing this, there were 44 residents, which we were doing this pediatric emergency medicine module. And we have data on pre and post test, the OSCE results, and some of their checklist-based results, which they were doing simulation scenarios using the virtual resuscitation room. So based on this cohort of my resident, I can predict that in next year when I run the same scenario with everything the same, who are the learners which are more likely to score less than 50% or more likely to score more than 50%. And the benefit of this kind of predictive AI is that you can focus on the students which are more likely not to succeed, and do some dedicated teaching, learning opportunities, pay more attention, give them some kind of task which will enhance their teaching and learning, and they are more likely to succeed at the end. So this is the 2 kind of AI which I'm aware of. There are many, must be any other kind, but that is still not come to my notice, or I haven't worked anything in them.
Because I think in a lot of our courses that we run, we do get a lot of questions from the participants from around the country. Kind of, how do I actually build a curriculum? How do I write scenarios? And this is something that, anybody could possibly use. They don't have to be an expert in writing scenarios as such. All they need to do is give it to AI and then just go over the scenario and just say, yeah, that's right. I don't like that bit, or, as medical professionals, but the actual scenario writing, which I think a lot of people struggle with, could be something that could be done by AI.
I was thinking about it in terms of like safety 1, safety 2 situation as well. If you have those adverse events that we don't really like to sim because we don't want to put anybody sort of focus under the microscope, but if it's a thing, or if it's something that kind of has happened more than once, you can put that data in to the generative AI, and it can generate again a sort of more objective, generic type scenario that fits within that sort of safety 2 bracket, and then nobody is sort of, no one group or a team is specifically under the microscope, but we're still able to explore that safety 2, scenario, and put, numbers of groups through that scenario, and then figure it all out. That's
a fantastic idea.
Fascinating. Yeah.
I think that's my little segue into talking about your work with using AI in the resuscitation room, and by using Beeline. If you want to talk us through something around what you've done at SimKIDS Toronto, in sort of like the AI-generated human factors reports from using Beeline, if you want to talk us through what you've been doing in that sphere.
Yeah, so basically in our resuscitation room, we have Beeline cameras installed, and a lot of our simulation scenarios get recorded, and one of my colleagues is looking into latent safety threats during those scenarios. And our trauma team, because trauma scenarios are very much well-defined, trauma 1, trauma 2, and they have started even the video reviewing of actual trauma resuscitation scenarios for continuous quality improvement, finding out some errors regarding near misses, and to sort out or look at the team dynamics and leadership that has been done in those scenarios. They are very challenging for the teams, and it is very, very clear. So because this is already ongoing, and we are planning to expand it to medical resuscitation as well. But for medical resuscitation, it is a challenge just because we cannot record and review every medical resuscitation, and like for trauma, most of the time EMS notify us they are bringing a trauma 1, trauma 2. Nurses have time to on the Beeline, and then we all know that it's being recorded, etc., etc. But in medical resuscitation, you most of the time do not get that heads up. There are critical moments that get missed if you are starting the recording at a particular time, etc. So these are still the challenges that we are sorting out. But the long-term goal is to utilize these recordings, which is from actual resuscitation cases, coupled with the use of AI-generated human factor report to get the feedback and analysis about some of the concepts of human factor, that how much is the movement is happening in the resuscitation room, in terms of finding the equipment, how is the communication happening, what are the communication patterns are, how teams are communicating, and where are some of the potentials where near misses or errors can happen or has happened. And then by utilizing this and generating those reports, we will be able, or we are hoping that we will tailor some of the training programs, implement this continuous quality improvement processes, and to have some objective performance metrics that we can utilize for certain cases. For example, time the time to CPR, the CPR quality, the time, how the team's handoff is happening, how much time they are spending, what is the composition of their teams, which composition work better than other composition. Those kind of things we can be able to analyze. And if we are able to create some meaningful data and show the people objectively that by doing that, by seeing their own recordings and somebody third person analyzing this kind of data and creating those reports, which can be sent automatically to the teams or can be relayed by us, will help in enhancing the patient safety and quality of care that we always aim to improve and provide to our patient.
It's amazing. Did you have any challenges getting legal? Because I know that sort of legally, it's always a bit of a minefield getting everybody involved. And, you know, there's always a dissenter in the ranks somewhere, isn't there, who doesn't want to be recorded, and I think it obviously comes from a place of sort of fear or that they're going to be scrutinised, and it's taking away from that and sort of saying it's not about you, it's about quality and safety, isn't it? So did you have any challenges getting everybody on board legally?
Yeah, definitely. It is, I think, I would say kudos to our trauma team leadership who struggled and did all our struggle from on our behalf, because they want to really implement. And, as a pediatricians or pediatric emergency medicine physician, a lot of team leader in trauma situation goes to general surgery. But we have been trying this, that the trauma leader should be PEM physicians. So I think because of that motivation, it's a lot of drive for them to take it upon and get it approved by our legal team, by I think our hospital administration, like our leadership, as well as our department leadership played a great role in getting those approvals from the legal department. And it is very, very explicit and very, very clear that this only be utilized for quality improvement. There's rules and regulations regarding how long these recordings will stay alive, and afterward it get automatically erased, and who has access to those videos. And what is the purpose for what purpose these videos will be utilized. So I think that clarity is very, very important. Otherwise, we all are aware that this can get into a lot of trouble, because we are actually recording the resuscitations, which is the most stressful event for parents, for caregivers, and for the whole teams, hospital teams. And the outcome of that resuscitation can be anything. It can be good, it can be bad. So for good, definitely it can be utilized as a kudos movement, but then if the outcomes are bad, then there are many, many legal repercussions that can that possibly hospital or healthcare providers can face if those regulations are not already in place.
Did you seek permission from the families? And how did you manage that at the time, or was it?
Yeah, that is an interesting question. Actually, that part which I think it is because when the resuscitation and all those things came in, there's no time to talk to the family. It is kind of already like this part I have to explore a little bit, that how we work around. But to the best of my knowledge at this point, when they get registered, there is a small blurb by informing this to them, and that is kind of not in front consent. It is just a implicit consent rather than an explicit consent for the parent.
I think it's such an interesting concept, isn't it? We can't learn unless we learn from actual events. And, we simulate. We always say to people, we're we're trying to improve quality and safety by simulating, but that also translates so heavily to actual events and what you're doing, you know, and the research around that and trying to sort of come out with the human factors and the health and safety from actual events. And how can you learn from that unless you record it and can see what happens and what everybody's doing in that time? It's such an interesting kind of field of research and so many sticky bits in it.
But they do it all the time in the airline industry, right?
I know,
Like it's just normal practice in other industries where if bad things happen, it can be catastrophic. So it's fascinating that we have this culture in medicine. I think that we struggle to learn from mistakes, and I think this is potentially. I feel like I see it as a window in terms of. It's not a human that's critiquing and again sitting behind the desk without all of the stress and struggle and strain. It's an AI generated report specific to human factors and to the bits and pieces that you know are you know safer, if you want, for want of a better word, in a safer format coming from a computer, for want of again better words.
Yeah. And I think there will be appreciation. I know it is at this point appear a little bit alien concept, but there will be an acceptance and appreciation because like in our normal day-to-day life, we always appreciate that if I accept my mistake and I'm ready and willing to improve and learn from those mistake as a human being as well, like everybody will appreciate that rather than penalizing me if I did something wrong. And I accept and I'm willing to improve and I'm asking help or activity. So I think based on the same concept, if we look at our psychology, it seems alien, but over time, providing it the lens of intention to improve, it might get more and more acceptability and will become automatic culture rather than something different. And frankly speaking, AI is it's just like to sort out that where that data is stored, who is having access and how long that they that have access. I think AI will be saving our time to generate that report. Like, for example, I was involved in one of the study where I have to look at the video and then rate a checklist. And there were, I think, 40 videos, and it took my, like, I don't know how many hours to look, to find, to just rate and fill that checklist. But if somebody can do it with the click, then what's wrong in it?
So many benefits. Oh my goodness.
Providing the opportunity to make higher level decisions and look from mental higher level, rather than just keep on doing that work which somebody else can do for me.
It's using, as I say, and I think as you said, you know, it's using that technology to help us. It's not using technology to kind of replace or, you know, instead of, or, you know, to lessen what we do, but to actually improve what we do.
Absolutely.
Save us so much time. Like, my God.
We're all very time poor, right? I feel like that's a worldwide phenomenon. Not just in medicine or sim, but in everything.
Right. And I think, like, just with...
It reminds me what my son, I was giving one day him lecture, that his name is Arshman, that Arshman, working hard is so important, and this and that. So he said, but Mama, I think working smarter is important.
He's got it nailed, eh?
Work smarter, not harder.
That's right.
Yeah, and the kids that are coming through are, like, all over this stuff, you know. And I think, like, just before we, you know, wrap it all up, Jabeen, do you have any, like, recommended resources for people that are kind of, like, have been, you know, maybe they're in the late adopter camp, but they've sort of listened to this podcast and they're like, the cogs are starting to turn, and they're sort of thinking, this seems really interesting. Do you have any kind of, like, resources that you would send them off to have a look at all?
I think the resources are now not openly available because whoever is working, for example, even we are working, we are just giving it a try, learning from it, making trial and error. But yes, there are some courses or some, I would say right now it is very important to understand what AI actually is and how it can help in medicine. For example, there is on Coursera by Andrew Ng is AI for Everyone is there, which I
cool.
found helpful in getting me understand a little bit. Then there is a book by Melanie Michel, Artificial Intelligence, A Guide for Thinking Humans is a good one, which I found interesting. I don't know whether we can hook up some of the articles linked
Yeah,
with this
let's do that.
podcast. Happy to send some of the articles which are now coming up into literature, that what is the role of AI in healthcare, what are some of the literature which is already available before we will move on.
Yeah.
So I think these are a couple of the things. I am happy to send you the
Yes.
links, and you can put in the
show
link
notes.
with the
That can be in
Yeah.
the podcast
Show
notes.
notes, yeah.
Show notes,
We will link anything that you recommend within to the show notes for the listeners. So thank you so much, Jabeen. This has been such a fascinating conversation. It's been really enjoyable to kind of hear about, we're lovers of VRR, to see kind of where that could potentially be going next as like an individual learning experience. All this language translation stuff has been incredibly fascinating, and I think has given a lot of information for us to kind of consider when we are translating for people in healthcare. And then all of this human factors stuff, Beeline and AI in the resuscitation room and human factors reports. Like, I think this is all really incredibly fascinating stuff. And I also just wanted to say thank you so much, Jabeen, for showing up online and sharing so willingly everything that you do. It's so inspiring, and I definitely would recommend following Jabeen on LinkedIn and Twitter, because she's constantly sharing all this incredible stuff that she's out there doing all over the world. So yeah, thank you. Thank you so much for fighting for equitable simulation for all, and I think the work that you do is so amazing.
Yeah, thank you so much. I'm also very much humbled being here and sharing some of these experiences. And I'm happy if anybody want to connect and learn more about them. I'm always available and happy to disseminate. I always say there's no need to reinvent the wheel. There's loads of already available. Reach out, have them, and then contextualize to your setting. So please feel free to reach out to me.
Oh.
Thank you.
Thank you
Amazing.
so much.
Thank you.
Very inspiring. I've got so many ideas now.
I know.
Thank you.
Thanks for listening to this episode of our podcast. It was made possible by the Starship Foundation and the Douglas Charitable Trust.
And special thanks go out to all of our amazing guests.
If you'd like to connect with us on Twitter or find out any information from any of the episodes on this podcast, just see the show notes.
Our Twitter handle is @StarshipSimProg, and our email is starshipsim@adhb.govt.nz. We would love to hear from you.